Welcome to Malignant Myths. I'm Kristiyana.
And I'm Athalia, and we are oncologists by day and mythbusters by.
Well, all the time. Our guest today is Dr. Sanjay Juneja. He's a hematologist and viral TikToker, as well as top voice of AI in precision oncology. Sanjay and I overlapped at Tempest AI for about a year, where he's still the VP of clinical AI operations. And Sanjay, I gotta tell you, I watched your TikToks before you started your job at Tempest, and then when I found out you are starting there, it was a surreal feeling, like getting to work with your favorite superstar. I was definitely starstruck.
And if it wasn't glaringly obvious to everyone listening, Kristiyana's still, in fact, starstruck.
I would say that you are very much a star in stealth. That I'm glad you're becoming more vocal because it just doesn't add up. The amount of experience and amenability you have, just in such a short period of time. So you are a reason actually because we ran into each other while I was doing my on-site. So I'm very humbled to be here.
Well, if you hadn't already guessed, today's show is all about AI. And in this brave new world of computers getting creative, a kind of recurring refrain we all hear a lot is, AI is coming for our jobs. So, as oncologists, give it to us straight, Sanjay. Is this a malignant myth, or should I have listened to the school guidance counselor and probably gone to law school instead?
I mean, so you'll have to forgive me a little bit for I've kind of philosophy roots and a lot of it which was in language. And I think we have to just remind ourselves what a profession or job is. I mean, I would argue that being human or an intelligent, human would at some point have been to know which way is north, south, east, and west, and be able to get home. If you were lost based on those features, and nobody really remembers north, south, east, or west anymore to get around, right? Because of the technological advancements. And I think similarly, we're just going to have a shift in the roles we, kind of ascribe and require of physicians in certain capacities or healthcare providers for that matter. I don't think the concept of physicianing or being an oncologist is going away, but certainly things change. And I think that's the main takeaway here.
All right. Well, let's start with the basics. How is AI currently used in the clinic in oncology? Everything from diagnostics, treatment, imaging, pathology, the whole continuum.
So the thing I get most excited about when it comes to AI, and I think the reason a lot of people are talking about it now is really this whole concept of generative AI. So when you think about generative AI, it means that it can generate something. And the thing that's the most common or people are most familiar with is language. It can actually give you and generate responses. And to do that, it needs a couple of core features that have to do with natural language processing. So that obviously what it says, right? Like it can understand and process natural language. And then these large language models. So like how can it interpret and understand what you're saying should you ask it something that's not algorithm specified, right? Like when you're on these little call centers that are automated or these older chatbots, there's a whole bunch of things that are okay, some version or derivative of this question, you're going to answer it like this is not what's happening. They're actually looking at every single word in succession and making sense and contextualizing what the question is. So that has really transformed, or one could appreciate how that's going to transform a clinician because it can generate things that you're looking for in number one, just very super busy charts, right? Like things are missed due to human fallibility, due to volume, due to decreased time that are just buried in charts, or worse, buried in the chart that you had nothing to do with in the management of, right? So it could be another provider, another specialist, et cetera. And these are all variables we desire to have the best educated, kind of treatment plan for any kind of cancer diagnostically, tolerance, all these other things. Now I could actually query those things. I can actually say, hey, what did the path report show? Did they have mutations? Did we get a path report or send it for molecular sequencing? Or, were there hepatic lesions on the right side because we treated it, quote unquote, oligometastatic, meaning definitively because there was only one on the left side, when we got a diagnosis of a barely stage 4 2 years ago. Like, I need to know these things on hand immediately, and I'm able to do that. Now, if you take that a step further, you may ask the question, well, if you can query things because of context in a chart, and something is quote unquote intelligent enough to pull it up, can we democratize care in the way of things that we know are not uniform? We know that things come out and say, yo, you're supposed to know about this in this second line setting. Yo, you're supposed to know about this when somebody's platinum refractory and check for it because there's a drug for it. We know so many of these things are coming out. Can you have something that in an automated way say this is that time or that indication or that instance, right?
Mm-hmm.
For XYZ. So one of the things is like EGFR testing. So that's been around for a long time now, molecular sequencing, because it can offer you an oral pill in an otherwise aggressive, stage 4 lung cancer. But we know it still doesn't happen 100% of the time. I don't mean given like treatment for it. I mean even checking to see if you have it when you're supposed to. So you can imagine that if you have these little agents or these people that are tasked with, okay, we need to know when EGFR is not tested in this thing where it's standard of care. We need to know if HER2 low isn't tested because it's apparently there's a drug for HER2 low now. And now I'm only talking about workflow stuff. I'm only talking about let's just get the bar even to hopefully reduce the number of gaps. This doesn't go into a lot of the stuff that Kristiyana, you know well, and others on actual scientific insights and discovery and how you can accelerate those things. What can we investigate? Realize we only investigate what we know, right? The mind doesn't know what the eyes haven't seen. Can we bubble up 10x the number of things that look appealing to be able to investigate into a trial? Can we use the context of patients' charts to fill these trials quicker? Because, we know there's not a single recommendation you will ever hear from a traditional oncologist, ever, in any line or setting, that wasn't on a trial and demonstrated. So when I hear on social media, when the drugs will get better, when are we going to do better? How come these things still whatever? Like, I have to say, realize it will never happen unless it's demonstrated on a trial to show that it's better than the status quo. And now we're finally able to fill these things quicker because that was always a huge gap or bottleneck in us getting those drugs that we all desire to be better. So these are all the things that I think AI, just a couple, will really transform what our understanding and delivery is in the coming years.
But what about when it it hallucinates stuff? We know that you put stuff into an AI tool, and sometimes it'll fill in the gaps. Are we arrogant as scientists, as physicians, to focus on this small percentage where we might get incorrect data and ignore the glaring holes in the number of patients who are not getting EGFR tested, HER2 low tested, whatever?
Yeah, I think so. I mean, we've kind of very quickly learned quite a few things about hallucinations in the last several months. Number one, just being, too sycophantic, like where it worries too much about how you feel. That's shown to cause increased hallucination. So if you can remove that, and a lot of people put that in their default in ChatGPT or whatever their choice is, then it's less keen on pulling something to give you either the answer in time. That's why people used to say take your time, because sometimes it would feel that it needs to send give you something quickly, or worry about flattering you or you being upset, blah blah blah. Then there's a difference on closed models and kind of constantly relearning models. So closed models, and especially point solutions, hallucinate far less than something that's constantly relearning. And then there's an in-between where you're looking at things that use a RAG, a retrieval augmented system. So it's trained, it's kind of locked in, and it just uses a RAG to go get the most recent information. And then you can put in things like traceability, right? That's a big one, which means if I'm going to query something in a chart and I need to know, if it had a left hepatic lesion, it'd be pretty nice to be able to have a link that tells me or pulls up that report and shows me, highlighted, this is the place where the left lesion is, just for proof. So you can have traceability, for example. So you can have all of these things that get into place. But I'll tell you, use the same principle. If you haven't done this, just hit spacebar, pause this podcast, go to, hit Control T if you're or Command T on a computer and type Sora to Stephen Hawking or Tupac and Biggie, and it's going to blow your mind, the video quality. I have Sam Altman giving me a haircut, pitching open evidence as a concept, and me just texting and not listening to Sam Altman. And it is unbelievably real. Could we have ever conceived that the AI would be that capable 6 months ago, let a year ago? So that same thing that's easy for us to appreciate in video, please understand that's the kind of stuff that's happening on this other technical aspect as well. And these confabulations or hallucinations were very real, a year ago, and they're still very real now. But it's unbelievable the way you can get creative and reduce the incidence of these things with what's coming out literally month to month.
Yeah, it's really exciting to think about the pace and scale of AI improvement and, like you said, how much has changed just over the last few months. Do you envision long term that AI will actually help improve outcomes for patients beyond introducing workflow efficiencies?
Look, cancer's been around a long time. How come we're improving by about 1%, improvement, in cure rates or whatever year to year for the last several decades? How come we're just not moving the needle fast enough, right? And then when you think about that, I realized that one of the reasons that feeling or sentiment happens from non-oncology individuals is because I take it as there is this large and growing aggregate of human tragedy that is cancer diagnoses and poor outcomes. This large growing aggregate. How come the needle isn't moving faster in spite this very large volume? And let me make this clear. One of the biggest reasons for that is because we can't dissect this aggregate of volume nearly like we want to. So I see, when I was full-time, I would see 20 to 25 patients a day, right? And I would see a lot of non-small cell and GI and cholangio and all this stuff. And then you take all these other people that have been doing it. Y'all, please understand, anyone listening, we are not examining these outside of what's called the anecdotal experience of somebody, in their observation, in their lens. So when somebody gets a cancer diagnosis, they'll be like, I get texts at least 5 a day from friends, family, acquaintances. Who do we go to in St. Louis? Who do we go to in Memphis has breast cancer? What are they asking? They're not asking you who the sharpest fellow is that came out. They're asking you who has a lot of experience, because they only have their focal impression of that volume in their space. And then of course they're going to read and everything like that. We can never as a whole, as human beings or as a scientific community, look at this aggregate. And so how are we supposed to learn? My point in beating this kind of nail over and over is if we, and now that we can, share all of the aggregate of experience, that breast cancer specialist in St. Louis and Boston and New York and in New Orleans and everywhere else, if we could actually start to unpack all of the different variables about these patients, what did they progress on first-line therapy? What were their mutations when they got diagnosed? What were their germline mutations or inherited, polymorphisms, the stuff that on how they metabolize? And just feed it into a crazy, reasoning, logarithmic ability to crunch numbers. Now I think we're going to start seeing pictures that are a lot clearer. Because right now, I'm pretty handcuffed in maybe a couple of options I have in a second line setting for most cancers. That's it. Doesn't matter if they're black, brown, white. Doesn't matter, outside of a couple of features on their molecular patterns. If I'm lucky, doesn't matter a lot. That's increasing. Imagine using AI to look at all of the case scenarios of what you chose, when you chose it, and everything that has to do with them, and having a line to help guide you on how much does this patient look similar? How much did they behave similarly? How much did their cancer behave similarly? To me, that is one thing that's more immediate, that the moment we all get it together and start sharing this data, because that's a huge problem, we just hold on to it. This is the delineation and the kind of sharpening of the pencil point that I think is immediately possible, technically possible, is going to take not having a personal incentives be the priority, but really the greater good and scientific understanding. And it's going to take a lot of just literally collaborating well. And I worry that we're in a system far too overextended, oversaturated, and busy and self-invested to really just get our crap together and say, how can we do this now?
So AI can do big data, aggregate case studies really well, better than a single physician sat in their clinic can. What about empathy? I sit here around the dinner table with my relatives, and they're like, yeah, a computer might be better, but I just want a doctor to like look me in the eye and tell me, in a way that I can understand and in a way that's empathetic, what's happening to me in this like really scary time. And I sit back and I think, phew, at least I've got that. Like I may not have all that big aggregate data, but I can break bad news. I can be the human at the end, other side of the table. But then I was reading online that there's a great study from Canada a couple months ago where they tested patient reception of empathy in large language models versus actual physicians, and they had to cut off the study after 45 patients because the AI was perceived as more empathetic by both patients and physicians. So where do I fit in the future?
It's an interesting question, and I think there's several verticals to unpack here. So since this whole concept of LLMs and avatars and chatbots, I say chatbots loosely because they're not really chatbots, but there have been, sadly, there have been people taking their own life due to something that they felt strongly about from chatbots. Okay. They're outperforming behavioral therapists and psychologists in several certain capacities of evaluation. So I don't think there's any question that a connection human to AI is not something that's not only possible but can be done well. Like I think that's already been demonstrated, right? Your study being one of those things. I think the question is we need to really define or think about what we mean by empathy, right? That to me is a big factor because think about it this way. There are physicians, say we're multidisciplinary, that are radiation oncologists, I'm a med onc, and surgeons that care about their patients like a lot, right? And they're very likable. And then you heard the first time and maybe a second and maybe a third when the patient's like, I don't care for them. So that's number one, is the perception of empathy and actual empathy. And I think, or we could all argue that regardless of what an AI model is appearing, I don't think it has the ability to be more empathetic. I don't know if it can be empathetic at all than a physician. Okay, so that's number one.
My gut feeling is that some of the discrepancy between empathy we know as physicians experience and what we can outwardly portray or what's perceived often is because of the time you have to spend with a patient, and all the burden on physicians that we know is there that hopefully AI will help alleviate. And it's hard to communicate that and find the time to communicate that when you have all of these other things you need to communicate to patients. So I think that may at least be a part of it.
I think you're exactly right, and that's the way we'll be very outcompeted is, this concept of always available and accessible is going to be very hard to break, especially when it has the ability to explain things really well. Realize that I can prompt, into something. I think one of the reasons that I'm quote unquote an effective communicator, or at least can help people get on board with scary drugs, is because I'm able to like really, come up with metaphors and explain things in different contexts. Like I always joke, like I'm a blue collar guy with a medical degree, so I can talk about it in car analogies and things like that. But if a chef comes to me or somebody that works in the kitchen and says, hey, can you explain chemo like in cooking adages? Sadly, me being an Indian oldest son that rarely is taught to cook with our mothers, I can't do it. Like I don't have enough knowledge. But if I were to say, talk to me like at a ninth grade level and only use cooking analogies on chemo and immune therapy, it's going to nail it. So take the Sora 2 video that looks so real, take the background knowledge that can put it in any context at any reading level and be very compassionate, and take the availability of 24/7 at any time that they're concerned that they can pull you up and you're going to talk softly and patiently and everything. So the perception of empathy is going to be very accelerated. The bigger thing, I was at Health last week, and then there was this one gentleman on the panel. He might have been contrarian by intention just for the sake of the panel, but he insisted, he swore that he believed trust cannot be earned. What he said was unidirectionally. He's like, so if there isn't actually listening back and forth, there's no such thing as trust. And I very much had a differing opinion, and that's because on social media, because of all these videos that I would put out on, like, this is how receptors work, and this is why immune therapy, all the things, why you get sick, where neuropathy happens, I would have such a long list of second referral requests, and I had to tell my office, and I had to email my EA emails them, because they were coming from MD Anderson, these top institutions. I'm like, dude, there's no reason you need to be coming to me for a second opinion. But it highlights that clearly there was a trust component, and there was never a back and forth exchange. It was just me having content, ample explanation, and lots of it that built trust or empathy, I would argue. And that's something that's pretty wild. So I think we need to really think about that and unpack it. I think I agree with you that we are, I think, for anything in the near to medium future, I think the most natural reception of a very scary time is going to come from a human. And I think we can have a lot of AI that assists us in so many ways, but I have to believe, and I want to believe, that interface is going to be important. But I'll tell you, last night we had a little Halloween party, and there was this cutoff of certain kids that were on my Apple Vision Pro that did not freak out on the dinosaur thing that was like in their face, even though all the adults did. And I think part of it is because they're getting kind of raised in this world where their brains, that primal primitive pathway that's superseding our frontal lobe, knowing this is fake and we still freak out, that was somehow overridden or shut off, or so strong to know it was fake that some of the younger kids didn't freak out. I think that's very telling on what other people are going to prefer, very much younger and different than us, and how they're growing up. So, all I can do, and we can do, and it's actually probably the main reason I do AI, is for preparedness. Am I bullish? Am I optimistic? Yes. Am I afraid of it? Do I feel uncomfortable with it and the changes that's going to happen in the timeline, that on how quickly they're going to happen? Absolutely. I would argue that's one of the main reasons I stay red on it, just as much, if not more, than what it can do to improve, the status quo today.
Mm. So shifting gears to tools that are currently available, like ChatGPT or Open Evidence, which is what's currently adopted by clinicians, really the ChatGPT for clinicians, and how those tools are used for patient education and decision making. Do you think those tools currently are helpful, or do you think they're risky, or perhaps a little bit of both?
I think if you would have asked me this question 5 or 6 years ago, then maybe I would say risky. And then we talked about this at the Nixon Cancer Foundation as an annual event, and a good one. And we had several leaders, and they were saying that the accessibility to information was overall, some of them, was overall dangerous, because things are taken out of context. It kind of impairs trust, because they say, why aren't you using immune therapy? Why didn't you check for this mutation? And then doctors haven't explained themselves and say, well, it's not applicable here. You're stage 4. This is curative setting, blah, 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 right? And I said 6 years ago, because it was very fragmented, to be able to recall things on the internet, on social media, etc. I think if you were comparing to that world, now add LLMs, it's made that less problematic, those things, because the context of what you're searching and the explanations are given so much more comprehensively than this very fragmented, kind of piecemealed way of going to WebMD and all these other things, by searching. So I think it's added a tightness. And sure, there might be a hallucination here and there. There might be something that's incorrect, but it is, goodness, really kind of focused what patients are learning and coming, here with. Now, let's talk about the physician or the provider's perception of these concerns, because they did not like, in general, this is just my opinion and my anecdotal observation, but maybe they're like, it just adds a lot to explain the why nots in a 15-minute visit, right? So like,
Yeah.
why we're not doing KRAS. Oh, you're KRAS positive, that's why we can't use this in colorectal. Every patient deserves all that, 100%. Or also, we live in a setting where like we know that time is just not at all statistically feasible. Now that's probably gone way up. And so now you're getting this overwhelmment of like of potentially doing this stuff that's like super elite, found out last week, when really you're trying to suit 10 different cancer types on patients in your area of all kinds of settings and just try to deliver to a standard care setting, which is where I think AI is going to help a lot, because once it goes into the physician side, instead of just being met with it, you also have these tools to kind of bubble up this, surface this, give us this beautiful paragraph on these are all the things that came out that are pertaining to the specific mutations of your cancer's phenotype. Now, oh, like that's relief. That's working on both ends, because that busy community oncologist gets this kind of extremely good fellow checking out and reporting on every single patient that they have in clinic pre-rounds. Like that is not a far-reaching reality. And I think that's where this gap of it being very available to patients and yet need to be demonstrated, validated, and accessible to physicians is going to put a little bit of a strain. I don't think that's going to last long.
Speaking of validation, can you talk a little bit about how AI tools are clinically validated, and are they held to the same standard as drugs or devices?
So I think that's something that's still evolving, very much so. So already we require like CPT codes and things. FDA is getting involved in certain capacities for AI tools. There's so many different versions, right? There's like AI devices, there's reasoning, there's AI things that are much more simple and less sophisticated. And then there's all these complicated factors on evaluating these things, like generalizability. Like one would say, oh, is it generalizable to any population? Like, should we include that? Others would say, well, maybe it shouldn't be generalizable because the people and population of Denver behave very differently in lifestyle than Baton Rouge or New Orleans. And so do we want to generalize a tool, because that's going to be very challenging, and now the people in Denver don't get the benefit if that's where it was trained, because we're saying that it needs to be generalizable in some context to people of a different demographic. Then you have things that about this validity concept. A good friend of mine is Dr. Deborah Patt, the EVP of Texas Oncology and COA president. And she'll say, like, we also need to think about great being the enemy of good. If we're just doing okay and we know that something is good, but not like, so let's call it, what you want, 80%, 85%, but we're performing it at 45% without the tool. Is 80 to 85% good enough?
Yeah.
Or we need to wait till 95 to 100% and just live at 45% until then? So these things become very challenging. And then I had somebody tell me in a panel I was moderating last week, they said, they flipped it on me. They were like, it's not only about regulation, on a state versus federal versus institutional level. They're like, should we regulate now, or do we kind of just, these things are already kind of trickling in, not replacing doctors? Should we just let them ride and wait till the mistakes happen to then understand better where regulation is needed first? Because there's so many places that need regulation. It's oversaturated. It's almost sometimes it's like, you're frozen. And so like, should we just see where those areas are and just kind of like very cautiously say, don't ever let it replace a human, and hopefully no humans will just letting it, affect something or overriding it now. And then getting a better idea in that capacity. So there are already things in place. Yes. I think a lot of them come with, I could call it even pride, like the people that are pushing these, not pushing, but developing these models and platforms and tools have their own internal, uh, 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 status or expectation. And so how rigorously they're vetting it is very important. They realize that, because do they want to be known as somebody that does that internally before they let it out in the wild or not? Right. So it's a very, figure out as you go kind of Wild West currently. And I think for that reason should never really replace what we're doing in a traditional capacity yet.
Yeah. What happens when an AI guided decision leads to a bad patient outcome? Who's responsible? Is it the physician? Is it the developer of the tool? Or the real question, I guess, is who do you think should be responsible?
So let's talk about the different places that one could be responsible, right? So number one, it could be the person that developed the tool or the company. Did they train it well enough? Was it validated? Was it rigorous? All the things that we just talked about. There is a responsibility, I think, for sure, on whoever designed that tool or model. Then, before it is put into an institution, there is usually an officer or a team, be it tech, innovator officer, whatever, that is going to ensure that that tool is vetted enough and comprehensively enough to be safe or utilized or investigated. There's somebody's job that at that institution to do that. Then it is the implementation officer. Is it done correctly? Is it right? Is there going to be then ongoing evaluation, comprehensive enough to make sure that it's still performing well? Because there's something called drift, and when things drift, it can actually not perform at the same level that it used to, and all that stuff. So then it goes to a physician or the provider team and is surfacing you something, right? And then it's the provider that takes this thing that chooses or not to deliver it to the patient or the patient's care. So to me, those are the different places, and to many, that one could assume responsibility. But let me ask this other question. If you are given a glucose of 500 in your clinic or a potassium of 6.5, so these are very high numbers that are concerning, and you give something to treat those two levels as a physician, and it was wrong. It was just wrong. It was another patient's. The machine wasn't calibrated. Whose fault is it? Truly. Was it the person that had to calibrate the machine that make sure it was okay? Was it the person that picked the machine? Was it the person that actually messed with the sample, or is it the physician's fault? And I'm curious to know your setting. I think a lot would say at the end of the day, the physician put it in order. Sure. But at the end of the day, that physician was acting out of incorrect objective information.
Right.
And I don't know what the answer is. Now, if the machine is not calibrated, so there's all these other things. So my point is, I don't know that that's super clear. I can tell you a lot of people are going to have a lawsuit if that were to happen. So it's to me right now, it's a similar thing that depends on kind of the circumstance and how obvious would it have been to every person or stop at play for when this would have gone awry.
Yeah, I mean, that's a great analogy to think about the whole context. And if something doesn't seem right, to think about repeating the test or looking at other data. But you're right, we have some learnings from other tools up to now.
So I guess the kind of follow up to that topic for discussion is understanding the tool. Like, I know, broadly speaking, how a blood glucose meter works and what kind of numbers I should be expecting. When it comes to AI, I mean, I went to med school in the early 2000s, and AI was sort of this pie in the sky idea. Is it the responsibility of all physicians, all clinicians, all providers to be now at this juncture getting on board, understanding what the acronyms mean, what the tech is, what the tech could be? Is it happening in medical schools already? Like, has it filtered down, like the kids in your kids' party who like now understand how VR works and know what to expect? Are the medical students and the undergrads and the high schoolers learning this stuff? Do they need to be, or can we just kind of sit back and trust the tool and wait for it to land on our clinic tables and then figure it out then? I mean, it's kind of a facetious question.
Yeah, I think it depends on, the capacity that you are thinking about the AI. Like, is it a point solution? Is it just to retrieve something from a chart, or is it something more comprehensive? I mean, here's something interesting. Let's talk about glucometer. There are multiple AI models that prepare yourself that are able to tell if your glucose is over 200 or below 120 just by talking into your iPhone. Just by talking into your iPhone, it can tell you what, not just if it's high or low, but even where in the range it's going. Now, how does that work? I wanted to know. It's, and I'm talking comparable to oral glucose tests, at least the one that was started in India. It's because it knows your baseline frequency of your voice so well that it can appreciate when you get the metabolic changes in acidosis and alkalosis at a certain level of this hyperglycemia or high glucose. It obviously changes something in your respiratory drive to accommodate for that metabolic change. And that change in your respiratory drive has a very subaudible but appreciable change in things that are called shrills or thrills that change the frequency that differ higher and lower between men and women. And that is an AI model. And it's already being shown to be able to increase the accessibility of the way that you can check for people that are walking around with unknown diabetes. So that is one example of, I need to know how the AI has done it. I don't know how the AI technical part does it, but I understand what it's paying attention to when it comes to frequency.
Fascinating. Very excited about the future. And this has been a very provocative discussion. We have a quick rapid fire true or false statement to end on. So first one, AI can read scans better than a radiologist. True or false?
I think true in the sense that some AI models can read better than some radiologists in some settings. I can't say it's completely false.
This is just for clickbait. It doesn't have to be correct.
Okay.
Your Fitbit data could be used for cancer risk prediction. True or false?
True. I believe it can definitely help you in many ways.
AI learns on its own like a human brain. True or false?
Totally depends on the model and if it's closed open. So I would say false. Not like a human brain.
All right. AI is already being used in tumor boards. True or false?
True. There are tumor boards where there's ambient listening and recalling of pertinent clinical information in real time just to have better informed tumor board conclusions, as well as sometimes facilitating even like I think GE Health is starting radiation oncology treatment protocols based on the discussions that it's hearing in tumor boards or punching it. Sorry, it's supposed to be rapid fire.
All right, last one. It's only a matter of time before AI escapes its confines and slaves human beings in a dystopian horror show. True or false, Sanjay?
Let's just go with false for now, as I'm known as an AI person.
Sounds good. Well, thank you so much for coming on the show. We really appreciate your time, your expertise, and raising a bunch of open-ended questions that we can all chew on before the next episode.
Oh, it's my pleasure. Thank you all for everything you're doing.